titrate suctioning, you'd be looking at your orders. You'd want to have your stethoscope because you might want to do a pre-lung assessment, listen to your patient's lungs, see if there is stuff to suction out. And then once you're done suctioning, you'll do your post-lung assessment. You will want to have your sterile gloves. This package does come with sterile gloves inside, or if you choose to grab a separate pair of sterile gloves that fit you better, that's fine as well. You'll want to have an oxygen saturation monitor on your patient's finger so that you can be monitoring their oxygen. You'll also want a disposable Chucks pad or towel over their chest, an ambu bag ready, and it looks like Leslie has tucked hers right back here. Wall suction and oxygen available, her suction catheter and saline. So her suction catheter should be in the kit, her little box for her saline should be in the kit, as well as some gloves. So her procedure, she's going to confirm the orders, gather supplies, hand hygiene upon entering the room, provide privacy, identify herself and explain the procedure, identify the patient with name and date of birth, review any allergies, set up workspace, assess lungs, assess oxygen saturation, assess their level of consciousness. Are they able to maintain their own airway? Or, and how's their breathing, coughing? She would raise the bed to a comfortable working height for her, and then as well as position her patient for the conscious patient in semi-Fowlers, for the comatose patient side lying. So then to begin the procedure, she would have that oxygen monitor on her finger. She'd position the ambu bag right next to the patient. She's going to turn on the suction between 120 and 150. And then that suction tubing is going to be in close proximity. She's going to want to have reached for that soon. She's going to have the bedside table cleaned off, and she's going to open up her kit. And she's going to open that up so that the sterile gloves are on the top part. So it's going to kind of seem opposite with this kit. That it's going to kind of be resting in the lid rather than the cavity, but it's going to be the best scenario for us. So she's going to open her saline. There's a brand new container. She doesn't need to lip it. If it was a used container, she would need to have a trash nearby to lip that. But that's open and ready to go. She'll don her sterile gloves.
This is why you might not want to use the kit ones. They like to stick to each other pretty good. You can decide.
So once she has her sterile gloves on, the next thing in her kit is her sterile suction catheter. She's going to pick that up, and she's going to take it out of the wrapper, and she's going to coil that around her dominant hand. And again, same thing with like Foley insertion. If you're right-handed, you'd like to want to be on the right side of the patient, left-handed, left side of the patient. She's then going to designate, she's going to use her hand to open up her box, and then she'll designate her non-dominant hand as her clean hand to pour the saline into her box, and then she's going to use that same clean hand to reach for the end of the suction tubing, and she's going to carefully attach that, and she's going to use her clean hand thumb to test the suction. Maybe even suck up a little bit of water, make sure it's working well. Okay. So then she's going to coil that up on her hand again and pre-oxygenate her patient. Again, she's going to be oxygenating them with the patient's breaths for that full minute. Okay, so it's been that full minute with his breaths. Then she's going to begin feeding the suction catheter down the trach. Again, suction is not on at this point. She's gonna feel resistance. Once she feels that resistance, she'll pull back that 1 centimeter, apply suction, and rotating the suction catheter slowly as she's withdrawing it. Again, that's taking about 10 to 15 seconds. She may rinse her suction line. She's keeping an eye on her patient's oxygen saturations, and then she may be giving him rescue breaths or rescue ventilation as well.
That should not happen.
You can repeat this again for a second pass. Again, if she was going to do a second pass, she would pre-oxygenate the patient for that full minute with his breaths. Advance that suction catheter again until resistance is met. It's met, she'll pull back that 1 centimeter and apply suction as she's slowly twirling and withdrawing from the trach. Okay? So then she could also, she's done with her tracheal suctioning because she's done her 2 passes. She could also suction the patient nasally and orally if she'd like. She would want to do nasally first because that also needs to be sterile. Again, she would advance that, apply suction and gently pull out. Again, keeping an eye on oxygen saturations. And then if she was going to do oral pharynx, she could advance that down the side of the mouth, rinsing the catheter in between each suction. Her orders today said to do trach suctioning and trach cares. So she's going to turn off her suction. She wrapped her catheter up in her glove, and she knows she's going to remove that soiled underdressing, and she's going to wrap those up into her gloves and discard them. She's then going to proceed into immediately doing her trach cares. For her trach cares, she would want her trach cares kit. She's also reviewed all of the orders. She'd gathered her supplies. Her supplies may also include 1 additional package of cotton-tipped applicators. So she may grab that. She's already reviewed allergies. The workspace is clean and set up. Her trash is still there. So then to begin her trach care, she's going to open up her trach cares kit. Again, if you don't like the gloves that come within this kit, you could choose to grab another pair of sterile gloves that are sized to you. She would also add the contents of the other cotton-tipped applicators into the kit. And then if she chooses to use this sterile drape to put over the patient's chest, she can put that down as well.
Could have removed that as well too.
Again, this has a shiny side and an absorbent side, so just that shiny side down. If the old dressing had not been removed, if she had not just completed trach cares, she would want to have clean gloves on and to have removed that old dressing prior to placing that sterile drape on his chest. So she's adding those into her kit. Then she's going to put on her sterile gloves so that she can rearrange her items within her kit. Inside this kit is going to be a new drain sponge to put underneath the faceplate. There's going to be a new set of trach ties There's also some other cotton tipped applicators, as well as the ones that she added. And then there's the normal saline solution as well as the hydrogen peroxide solution. She's just grabbing all of her 4x4s and dressings, kind of fluffing them out so it's easier for her to grab them in a moment. There's 2 packets of hydrogen peroxide. Doesn't look like she needs both.
This brush likes to stick to these, so you might want to figure out a way to like keep it separate.
I'm gonna open her hydrogen peroxide and pour that into one of the little cavities.
I got rid of that.
And then she's gonna open the normal saline and put that in the other cavity. So the sterile part of this procedure is cleaning that inner cannula. So again, she's gonna designate her non-dominant hand as her clean hand. She's gonna turn the inner cannula so it unlocks. She's gonna carefully slide that out so it's not bumping the patient's chest. She's gonna dunk that in the hydrogen peroxide, probably grab her scrubby brush so that she can clean the inside and outside of the cannula well with that hydrogen peroxide solution. Note that she's not letting go of it. She didn't set it in there, and she's only touching that outer portion of the white cannula. That's the part that's exposed to the outside, so she's not touching the part that's gonna be inside the patient that needs to remain sterile. She's gonna then dunk it in the normal saline to rinse it. She might choose a cotton tipped applicator to make sure that that's good and dry on the inside and outside. She could even use one of the 4x4s to thoroughly dry the outside. Once that's good and clean and all the way dry, she needs to replace the inner cannula back in the patient, being careful not to bump or touch that anywhere, and turning it to lock it back into place. Okay, so the sterile part of the procedure is mostly done at this point. Then she's gonna pick up her cotton tipped applicators and dunk it in the saline, and she wants to clean around the faceplate. So she might choose to do a swipe underneath.
One time.
And she might choose to do a swipe along the top. And again, depending on how many secretions are dried or built up there, she may need more cotton tipped applicators.
6 or so in there. So this would be a new one.
And then she would want to clean on the front of the faceplate as well.
Another new one.
She could then use one of the 4x4s to pat the area dry on the skin and the faceplate to make sure everything's dry. Next, she needs to replace that drain sponge that goes underneath the faceplate. So she's going to find that drain sponge, and she has the slit pointing towards the 12 o'clock position. She can fold that down, and then she'll kind of set it at the base underneath the faceplate, and she'll kind of gently work those flaps up and underneath those ties. Once that dressing is replaced, the last thing she needs to do is replace the trach ties. You would always want to secure your new ties prior to removing the old ties. It's safest to have it doubly secured and before not secured at all. So she looped that through. And then she's just gonna tie it in a knot, just how you know how to do when tying a shoe.
Just know that you don't want it too tight. Remember your 2-finger rule.
So again, making sure it's a good tightness. She's gonna remove the old tie. Once that old tie is removed, she's gonna clean up her equipment, remove her gloves, reposition the patient comfortably, do any post-assessments, and she's gonna go document. Some of the things that she'll document include how the patient tolerated the procedure, any patient teachings that were done, her assessments that she did of the stoma and any of the